This morning, we have a great lineup of speakers. I'm going to bring Dr. Robert Lebovics to the podium so he can introduce our first one. Thank you.
Good morning, everybody. Thank you, Joyce. Welcome. I'm Bob Lebovics. I'm very fortunate to be on the board of directors of this wonderful organization. It's your organization, and the fact that you're here just says wonderful things about advocacy, knowledge, and hopefully will be part of the solution from the patient perspective because you're critical. That sort of segues into my introducing our first speaker, Dr. Eric Matteson. And I just want to tell you, let me just start off starting off with a headliner right here. For those of you who don't know who he is, he's the chairman of the Department of Rheumatology at the Mayo Clinic. Now, that's a little hospital in a small town somewhere in the bottom of Minnesota, right near the Iowa cornfields. But with all that said, the Mayo Clinic, obviously you know what it is. He's a professor and chairman. He's been involved in the VCRC, which is, you can hear more about this later. Very involved in systemic vasculitis. Dr. Matteson also has particular interest and expertise, probably world leader in GCA. Probably that segues into the other concept of vasculitis in general. His work there transforms other of the vasculitides, Wegener's granulomatosis GPA, eGPA. And to say that he's a headliner, I think is an understatement. So I just want everyone to give him a warm welcome. Dr. Matteson, come on up.
Thank you for that overly generous introduction. I'm not so sure about the headliner. There's a whole lot of very impressive researchers here that you're going to be hearing from and have heard from already about vasculitis. And I'm going to touch on a topic of vasculitis that is familiar to many of you if you are over 60 years old and have been in contact with somebody who has giant cell arteritis, and maybe not so familiar to you if you're not in that geriatric age group. Now, I was at a meeting of the British Society or the British Support Group for Vasculitis patients a couple of months ago, and we were working on Polymyalgia Rheumatica, which is a condition associated with giant cell arteritis. And it has traditionally been referred to as a disease of the elderly. And it, as time goes on, is a definition that I keep pushing away. Elderly, what is elderly? Well, in vasculitis, if you're over 50 or older, and most of us don't really think about ourselves as being elderly at the age of 50 or 60 or 70 or sometimes even 80. And the concept of this being a geriatric disease is one that I think is starting to disappear. It's a disease, Polymyalgia Rheumatica, that, these are my disclosures, by the way, these are different research efforts that I've been involved with that may touch on this topic. It's a disease that has a lot of mimics, just like many forms of vasculitis have mimics. You all know that it's very confusing to diagnose vasculitis, to be diagnosed as having vasculitis, because there's so many different things that look like vasculitis, and there's so many different forms of vasculitis. And vasculitis you can think of as being a spectrum of conditions. It's like a rainbow, and sometimes you don't know where you are in the rainbow. Are you on the orange side, or are you on the purple side? You don't know where you are in the rainbow either, as far as how bad your disease is going to be. So I think that the idea of the rainbow, the spectrum, is one that is really applicable to this discussion about polymyalgia and about vasculitis in general. So we're going to talk this morning a little bit about polymyalgia, how it relates to giant cell arteritis, how it relates to some other diseases, and how it gets confused with other diseases. And I'm going to discuss those in terms of some of the inflammatory conditions, autoimmune conditions, and other conditions that occur in not the elderly, as the people in Britain are admonishing me to not say, but rather older people. So in terms of background, polymyalgia actually turns out to be the second most common inflammatory rheumatic disease in older persons, and it occurs mainly in people who are 50 years of age and older. It's very difficult to diagnose this condition sometimes because there's so many mimics. There's such a big spectrum of this rainbow, and a lot of the symptoms that happen in polymyalgia occur in other diseases as well. There's not a specific laboratory test, unlike, for example, some forms of vasculitis, and there is significant overlap in the disease with other conditions like rheumatoid arthritis and a number of different forms of vasculitis. And so we think of a spectrum of disease going from polymyalgia, rheumatica, rheumatoid arthritis, ANCA-associated or diseases like GPA, spondyloarthritis, and then there's all kinds of other diseases, metabolic diseases, degenerative diseases, and inflammatory diseases that look exactly like polymyalgia rheumatica too. So how to think about polymyalgia rheumatica is sort of like how to think about your relationship with your spouse. It's kind of what direction are you coming at it from. And when a patient goes to a doctor and they have a certain number of symptoms and kinds of symptoms, you've all had this experience, and certainly as doctors we've had this experience, you're saying one thing, we're hearing another thing, and you're hearing something different than what we're hearing, and it's almost sometimes like talking with your wife about where you ought to go for a vacation, or what you ought to do with your children, or any number of other things. So it is the full range of human experience that actually comes into the examination room when we're talking about symptoms of these diseases. And to highlight the conundrum already, people with giant cell arteritis very often have symptoms of polymyalgia, and what those are I'll come to in a second. But just to set the stage, 40% of patients with giant cell arteritis have polymyalgia, 20 to 40% of patients with polymyalgia have giant cell arteritis, and 20 to 40% of patients with suspected polymyalgia or giant cell arteritis have something else altogether. So you can see already we have quite a conundrum to deal with. Some of the things that patients who are evaluated for polymyalgia rheumatica and other form and vasculitis that's associated with polymyalgia, which is giant cell arteritis, come to the doctor for are things like fever, weight loss, and fatigue, and in polymyalgia, very typical symptoms, severe muscle pain in the shoulders and in the hips. This is something that happens fairly acutely, often over the course of 1 to 2 to 3 weeks. Something really out of the ordinary, which if untreated, progresses to the point where people can't even get out of bed without help. They can't get their arms above their heads, they can't do their hair. These are some of the symptoms of polymyalgia that are really limiting to your ability to take care of yourself in your normal daily activities. It can be associated with not only joint pain, but a profound amount of morning stiffness. And I don't mean the few minutes that it takes us to get loose when we first get out of bed in the morning, but an hour, 2 hours, or even more of stiffness before we finally get moving. And there are a number of other scenarios of systemic disease that occur in older persons that get confused with polymyalgia, get confused with vasculitis, or maybe part of vasculitis, like these kind of skin lesions, including ulcers on the skin, nodules on the skin, and so on. Actually, the concept of polymyalgia may be new to some of you, but it's something that has been around for a long time. In times past, in the 1800s, it was called senile. So if you don't like the concept of geriatric disease, think about being called senile and having a senile disease. Senile rheumatic gout is what this was called. And a doctor by the name of William Bruce, already in 1888, described patients who had severe severe pain and stiffness of their shoulders and hips. And he was already confused. And he said that this kind of condition disturbs the lay mind and gives occasion for remarks as to the uncertainties of medicine. In other words, what he was saying, the patients think the doctors don't know what they're doing. And I think that that was definitely the case. So what is it that gets confused with polymyalgia and giant cell arteritis? What are the components of this rainbow? These are some of the things that I'm going to just talk to you about very briefly to give you an idea of some of these conundrums, and how you think about these things really depends on what your personal view is of your health and what the training is of your doctor. So here's a first case. This is a person who we evaluated with stiff shoulders and hips. She was a 70-year-old woman with worsening shoulder and hip pain over the past 2 months, to the point where she required help from her husband to get out of bed, to get dressed. She awakens frequently at night because of pain. Her appetite is poor. She's lost weight. And she was diagnosed with an inflammatory disease. She was given cortisone and she got better. This is actually that case. This is from 1960. This was shortly after the term polymyalgia rheumatica was used for the first time, which was in 1958. And this patient received corticosteroids. And you can see in the top picture, this is where she wasn't able to get her arms above her head. She got steroids and she scored the touchdown, it looks like. So is that polymyalgia? Is it giant cell arteritis? It's really hard to know. I already explained to you that 40% of patients with giant cell arteritis, the most common form of vasculitis occurring in older people, have polymyalgia, and about 20 to 40% of patients with polymyalgia have giant cell arteritis. Well, we tried to look at this and see if we could dissect it apart a little bit. And basically what we found out is that people who have giant cell arteritis, of those people, about half of them already had symptoms of polymyalgia when they came to the doctor and were diagnosed with giant cell arteritis. And after the onset of the giant cell arteritis, the pain that's very typical in the head, sometimes visual disturbance, then some patients also developed polymyalgia rheumatica. And it's really hard to tell these things apart. But there are some ways that we can think about the diseases that will help us. And as we think about these diseases and we think about what could it be, this is the kind of thing that goes through our head. This is a really complicated scheme. And what it basically says is that if you have shoulder pain, it's new shoulder pain, and there are symptoms like weight loss and fever, it could be any number of things. And so we have to think through a whole spectrum of diseases, going from thyroid disease, for example, or lupus, or even osteoarthritis, septic arthritis, and cancers, before we can actually come to a correct diagnosis. Now, in polymyalgia rheumatica, one of the key things that happens is that there is inflammation in the structures around the major joints, the shoulders and the hips particularly. And there have been studies that have been done to look and see if we can find inflammation in the lining of the joints. In fact, we can. And studies today using, for example, magnetic resonance imaging can show us evidence of inflammation. This is inflammation in the bursa of a patient who has polymyalgia rheumatica. This is the head of the upper arm bone here. This is actually a shoulder. This is a shoulder blade. And so we can actually see inflammation in those joint structures. We can also see the inflammation on ultrasound as well. And some of the typical things that we find, this was a patient that we evaluated recently who had a very high sedimentation rate. She also had a high CRP, which is a marker of inflammation. Her rheumatoid factor was positive, and she was evaluated because she had what we call proximal joint pain. That means in the shoulders and hips. And she had swelling here that was noted in the shoulder. All of this black represents fluid that was in the shoulder. The MRI also showed us evidence of inflammation around the biceps tendon, and she had bursitis as well. And as we further examined, then we could also note that there was inflammation in the joint itself. There was also inflammation. This is another example of another patient where you can actually see the inflammation in the hip on ultrasound. So a very simple technique, if applied properly, can help to diagnose inflammation in joints. And here, this is actually the hip bone, and this black represents fluid that's collected in the hip. And even trochanteric bursitis, which I'll bet there's people in the audience who have had trochanteric bursitis, can be a part of polymyalgia. And even on ultrasound, you can find evidence of inflammation. So that's a very helpful technique we're learning to assist us in the diagnosis of polymyalgia rheumatica, but all of these findings can be seen in other conditions too, like this one. This is a lady who is 75 years old. She had swollen hands. She had trouble doing her housework. And she then said that she tried ibuprofen. That wasn't very helpful. And when she came in, we could see that she had swelling of the hands. And it turned out that she actually had rheumatoid arthritis, but she also had problems with shoulder and hip pain. And so that was a part of the spectrum of disease that we think about when we think about patients with polymyalgia rheumatica. And this is another patient who had a very similar type of problem with swelling also of the hands. But this swelling was a little bit different. This swelling wasn't so much in the joints, but rather it's in the tendons, the tendon sheaths of the hands. And this is something that is thought to be very highly associated with polymyalgia rheumatica, and sometimes in giant cell arteritis if a person with giant cell arteritis has polymyalgia rheumatica also. So a very peculiar type of swelling in the hand that can be associated with giant cell arteritis or polymyalgia rheumatica. It's called RS3PE, and that refers to the fact that it's synovitis that keeps coming back, and we can see evidence of the synovitis, for example, on this ultrasound where there is fluid around the joint. This is a knuckle joint that shows some fluid, and this is a hand MRI, and in the MRI there's also evidence of inflammation in the tendon sheaths. Here's another person with a spectrum of disease that we're talking about, PMR-GCA. This is a 76-year-old woman. She has new onset temporal headache. So headache right here, a typical symptom of giant cell arteritis. She has fatigue, weight loss. She has high inflammatory marker called the C-reactive protein. She was placed on prednisone. They tried her on methotrexate. It didn't really work out. And this patient had, when she was diagnosed, also an ultrasound done. The ultrasound was done of the temporal arteries and showed inflammation. This black halo here along the artery is a sign that there is inflammation in the wall of the artery. So that's kind of helpful for us. And so that was done when she was diagnosed, but she didn't get better on the steroids, or she only got partially better. And so we tried to figure out why is that. And the reason that was because she had inflammation of the big arteries. This is the aorta coming out of the heart, so the major artery of our body that supplies the blood to every place else in the body. And here what we see is that there is a little black stripe or a gray stripe next to the aorta that shouldn't be there, right here. And that represents inflammation in the aorta. So this person came into the office was diagnosed with giant cell arteritis on the basis of the temporal artery headache, that ultrasound, and didn't get better as fast as we thought she should. And it turned out that the reason for that was that there was inflammation in the large blood vessel, the aorta. Now, let's see here, so what we're talking about then is a spectrum of disease. I put giant cell arteritis in the middle because I think that giant cell arteritis is for us, the focus. Dr. Wyand will be talking to you a little bit more about this later on today. But giant cell arteritis is a disease that has lots of different associated conditions and lots of different ways that it can fool us. So the spectrum, or the rainbow of giant cell arteritis, goes to polymyalgia rheumatica, or large vessel disease like I showed you, or you can have polymyalgia and you can have giant cell arteritis together, a condition that in 1958 was already termed polymyalgia rheumatica. So what separates these things? Dr. Wyand, who's here in the audience, did a study a long time ago already, I think 1994, where she looked at some of the inflammatory markers in the blood of patients with polymyalgia rheumatica and patients who had giant cell arteritis and different forms of giant cell arteritis, and she'll talk to us some more about that. But the important thing was that there are some differences in the inflammatory proteins between these diseases that govern what kind of disease you're going to get. And we don't know exactly how that happens. She'll shed some light on that, but you can see here that there are important overlaps between these diseases and all of these inflammatory markers, and that explains a little bit also why we have such a rainbow of disease as well. People have looked at genes of patients with rheumatoid arthritis and giant cell arteritis and polymyalgia rheumatica, and it turns out that many of these genes are shared genes, and it's really hard to separate these diseases on the basis of genes. There are a couple subtle genetic markers that in some patients are helpful, and some of these are underlined here. It doesn't matter if you can't see them. We don't use these on a clinical basis, but we use these to study these diseases. And what we learned was that there are some subtle differences in the genetic makeup of people with these diseases, but the genes don't help us to separate the diseases very well. So what else can we talk about then in the spectrum of disease? Well, another important condition is cancer. So this was a patient who had also typical symptoms of polymyalgia rheumatica. He had shoulder pain and hip pain. It turned out that this patient had metastatic prostate cancer and not polymyalgia rheumatica at all. This was a patient who had ANCA-associated vasculitis, and this patient actually presented with general joint pain and fatigue and was thought to have polymyalgia rheumatica at first, but then started coughing up blood, and it turned out that this patient had GPA. This is another patient who came to us with bilateral shoulder pain. New onset shoulder pain, was thought to have polymyalgia. The sedimentation rate was elevated, and what actually was going on was that the aorta was expanding. This patient had developed an aneurysm because of aging, actually, and it showed up as shoulder pain, but it had nothing to do with polymyalgia rheumatica. So a very confusing kind of situation. And finally, here's another patient, a little bit younger, 53-year-old, who also came in with bilateral shoulder pain, morning stiffness, all those things that I talked to you about. And it turned out then in the end that he had something called sacroiliitis or ankylosing spondylitis. This is an MRI of the pelvis that shows inflammation in that area where your hip bone joins your backbone. So not polymyalgia rheumatica either. A little tip here was that he was only 53 years old, so pretty young for polymyalgia rheumatica. Now, I'm just going to skip over a couple of slides. What I would like to just emphasize is, as we think about this spectrum of disease, all of the symptoms are not specific. That is, they don't tell you, oh, it has to be that disease, it can't be anything else. So we have to carefully think through what the patient is telling us and what we're thinking about, and we do some basic blood tests, which are these, and we think about some of those conditions that can mimic polymyalgia rheumatica that we have talked about, and then we treat with steroids. And we think that if a patient gets, many doctors think that if a patient gets better when they take steroids, it must be polymyalgia rheumatica. That's not at all true. Almost all the patients that I showed you who had cancer and other conditions got better on steroids and didn't have polymyalgia rheumatica. So that is not a good way to think about this, and that's a fallacious thought process that many doctors still have today. We have some new ways of thinking about diagnosing polymyalgia rheumatica. We just recently have published what we call classification criteria. Basically, what we're talking about are sets of symptoms that when we take them together and then add the ultrasound, which is helpful, we can say with reasonable certainty a person has polymyalgia, at least for purposes of study, and not some other condition. Some other clues, though, that we're not talking about polymyalgia. If the patient's young, less than 50 especially, if the rheumatoid factor is positive, it's probably not polymyalgia. And if there is ankle involvement, it's probably not polymyalgia either. The management of polymyalgia right now is with steroids. There are no other drugs, really, that help with polymyalgia rheumatica. We also pay attention to the kind of problems that people get when they are on steroids and try to mitigate those, such as high blood pressure, hypertension, diabetes, and so on. And one thing that we know from polymyalgia is that it's a long-term disease. If you have polymyalgia, like giant cell arteritis and many of the forms of vasculitis that we're talking about here, they're chronic diseases. You're on treatment for a long time, and in polymyalgia, it's at least 3 years, but we have patients who have had disease for 10 years or more. It's very unusual to go through the rest of your life once you're diagnosed without having a flare-up or a recurrence of the symptoms of polymyalgia. That's basically what this shows. But some good news about it, it is a controllable disease. There's concern sometimes that cancer risk is increased with some of these diseases. That's not the case. Life expectancy in polymyalgia is not impaired, and we're developing some new drugs that hopefully will reduce the steroid burden. Some final thoughts about polymyalgia rheumatica. We think of polymyalgia rheumatica kind of, at least in Minnesota, as, of course, as a disease of Vikings. And we see lots of giant cell arteritis, polymyalgia rheumatica in Minnesota. The highest numbers of people who have these conditions are people of Northern European ancestry, so people from Germany, from the Scandinavian countries, not exclusively. Maybe one of the first cases of giant cell arteritis ever reported was in the 11th century from Persia, but for the most part, people are from Northern Europe. And I think that what we need to always be aware of, this is a condition that has lots of mimics. You have to be critical when you're being treated for it. We always have to think about what else could be associated, including giant cell arteritis. And as we think about going through life with a condition like this, I think that we have to think about our ultimate geriatric challenge, which is staying young at heart. And with that, I'd like to thank you for your time and attention. I'd be happy to take a couple of questions. Thank you very much for inviting me. Or did I answer all the questions? Yes, sir.
Giant cell refer to? What type of cell is that?
The giant cell in giant cell arteritis refers to a cell that's seen when the tissue, the blood vessel, is examined under the microscope. And it is a particular type of cell that is characteristically found as a result, or maybe even as a part, let's say, of the inflammation of the blood vessel. And it's a cell type that's seen in giant cell arteritis, but not seen, for example, in patients who have granulomatosis, polyangiitis, or other forms of vasculitis. There is a condition called Takayasu arteritis, which some of you know about. These types of cells can be seen also in the vessel walls of patients who have Takayasu. And we think that those cells are important in the disease process. Dr. Wyand is actually probably going to talk a little bit more about that later on, so I'll leave the rest of it to her. Yes, sir.
Really clinical studies that show patients that indicate all of the three parts of vasculitis, the nervous, the small, medium, and the large arteries. And you have those patients that you know about how long, how are you treating them, is it possible, do you have any indication of what caused them?
So, what caused these?
Somebody got all of them.
So many forms of vasculitis, as you saw here, and as for giant cell arteritis, polymyalgia, affect many parts of the body. They're systemic diseases. How they affect individual organs differs by the different forms of vasculitis. And we don't know exactly why that is. We think that there are what we call tissue trophisms, which means that in, for example, our blood vessels, one blood vessel, one artery is an artery in the head is not exactly the same from a molecular standpoint as the aorta, for example, or an artery in our finger. And there are undoubtedly differences that account for why some of those arteries become involved and affect certain organs and why others don't. But we don't understand exactly how that comes about.
Are you familiar with the broad people that people have? Can the eye be affected across the whole spectrum?
Yes, certainly. In some forms of vasculitis, for example, the ANCA vasculitides like granulomatosis, polyangiitis, or Wegener's or Church-Strauss disease can do that, yes. All right. Well, thank you. Oh, yes, ma'am.
Thank you.
Giant cell arteritis makes your gait unsteady.
So in general, giant cell arteritis doesn't affect the arteries inside the brain to cause stroke. It can. That's more unusual, though. If you have a stroke due to giant cell arteritis, then it can make your gait unsteady. That's a little bit unusual, though, in giant cell arteritis. It's not that it doesn't happen, but it's pretty rare. What can happen more frequently is that giant cell arteritis affects your eyesight. And if you develop diminished vision or even blindness, that can make you very unsteady in walking. All right, well, thank you very much.